Hello everyone, my name is Lewis Hodder. I'm an advanced care paramedic working out of Brisbane, and today we're going to be running through an RSI in a 27-year-old male, GCS 8, who is apneic secondary to a drug overdose. So for the safety precautions for this scenario, we're going to have to wear a face mask, a mask with a filter, a gown, glasses and gloves, as well as adhering to the 5 moments of hand hygiene. For the purpose of this scenario, we will not be wearing all this equipment, however. So guys, just to recap, we're going to be doing an RSI on this 80 kilo male, 27 years old overdose patient. So for this, we're going to pre-oxygenate Mitch and I, just starting with a 2-person technique with bag mail mask, and we'll run through the checklist as well.
Excellent. So the first part of the checklist is pre-oxygenation. So bag valve mask with PEEP valve.
Yep, BPM, PEEP valve attached.
Excellent. End-tidal CO2.
NTO's end-tidal CO2 attached and working.
Excellent. And inflated face mask.
Yep.
Have we got an OP?
OP in situ and MPAs underneath.
Excellent. Consider high flow oxygen via NP.
So nasal pumps attached at 15 litres.
Excellent. And our oxygen source, we've got supply, flow and good connection.
Yep, 2 sources, both running at 15 litres currently with a full tank.
Okay, moving on to part 2, which is assessment and monitoring. Did we have a BGL that was within normal?
Yes, we did.
Have we assessed basic neurology prior to the RSI?
We have, GCS 8 patient.
Excellent. Have we got ECG?
We do, normal sinus rhythm.
NIBP?
NIBP, 120 on 80.
SATs?
SAT's good, currently at 99%.
And we already mentioned the end-tidal CO2, which is mandatory in the circuit for an RSI.
Yep.
Access-wise, have we got patent IV or IO access? Has it been visualised?
We do. We have bilateral access with fluids running on the right, on the left side.
Excellent. And they're flowing freely?
They are.
Excellent. Suction. Do we have a suction catheter?
We do. Suction's been tested to my left.
Excellent. And we've got a secondary unit?
We do.
Excellent. Equipment-wise, have we got 2 laryngoscopes?
We do. We have 2 laryngoscopes, size 4 and size 5 behind them.
Endotracheal tube and spare with cuffs checked?
We have size 8 and size 9, cuffs checked and lubricated.
Have we got a bougie?
We do have a bougie.
10mm syringe?
We have a 10mm syringe attached to a manometer.
Do we have a tube tie?
We do have a tube tie.
Do we have an LMA available?
We have an LMA set up at the top.
Excellent. Do we have a surgical airway available?
We have a surgical airway set up.
Do we have a manometer?
We do have a manometer.
Excellent. Now on to part 6, which is the position of the patient. Has the patient position been optimised?
The patient's position has been optimised. They're in the sniffing position and ramped with the ear level with the sternal notch.
Excellent. Do we have manual inline stabilisation, or is it needed for consideration of C-spine injury?
No consideration of C-spine injury in this patient.
Okay. Moving on to the drugs for this RSI, our induction agents.
To do this, I'll just go back to single person BVM, which is working successfully.
We've got fentanyl, 100 mics in 10 mils.
100 mics in 10
that
mils.
expires next year.
Wonderful.
We've also got ketamine, 200 milligrams in 20 mils, and that expires in 2023.
220.
And rocuronium, we have 100 milligrams in 10 mils, and that also expires in 2023.
Rocuronium as well.
Okay. Our doses for the RSI are going to be?
So the dose for the fentanyl, we have 100 micrograms. For ketamine, we're going to give 80 milligrams, which is 8 mils. Rocuronium is 96 milligrams, which will be 9.6 mils.
Perfect. Do we also have a presser?
I'm advocating for the use of a noradrenaline infusion as a pressor. The reason for this is I believe the extravasation risk has likely been exaggerated according to research. It has the safest physiological profile if you were to compare it to dopamine, which causes arrhythmias at a high rate, and adrenaline, which increases lactate. It offers benefit there. It also has the benefit of being an infusion in contrast to say metaraminol as a pump. Unfortunately, we couldn't access an infusion pump for this scenario, but it would be set up to the right with its own dedicated line.
Now on to section 8, which is briefing the team prior to the RSI.
Wonderful. So guys, obviously know our roles. So Mitch, your circulation assistant, it'll be your role to push the drugs and to monitor the patient's vital signs. Key there is to make sure that you let me know when the SpO2 drops to 95, 90 and 85. Alex, as another CCP, you'll be my airway assistant.
Yes.
So it'll be your role to help me with positioning of the patient, passing the bougie, passing the tube, and assisting there. Now, if we do have a failed first attempt, it'll be your role to do a second attempt as senior clinician. And then from there, if that fails, we can then go back to our SGA or bag valve mask. Given that the bag valve mask is working successfully, there's a good chance it'll work again. However, that may change with the administration of the rocuronium. If they both fail, we'll be at the bottom of our vortex, and then we'll be looking to do a surgical airway. That's prepared there, and the cricothyroid membrane has been marked on the patient. This setup assists in decreasing cognitive load, establishing a plan if things go awry, and having everything set up and easy access for myself and the airway assistant. Is
Very
everyone happy with their roles or have any questions?
Happy.
All right, let's crack on. Mitch, can you please administer the fentanyl for me? And
Yep,
what's the
fentanyl.
dose?
Yep, so 100 micrograms of fentanyl in 10 mils, pushing 10 mils.
And just noting times on the Alex.
Excellent. So that's going in at 11:55.
Fentanyl's in. So ketamine, going to give 80 milligrams of ketamine, which is 8 mils.
Yep.
Got that one as well.
That's 11:55 also.
All right, rocuronium, so this is the 96 milligrams, 9.6 mils.
Yep, 96 and 9.6.
Rocuronium's done.
Excellent. That's at 11:55 and 50 seconds.
So the role now, obviously with our pre-oxygenation phase, we want to ventilate for at least 3 minutes. We're looking to flush out the nitrogen from the lungs, increase our SpO2 as close to 100% as possible, and increase our pH O2 to 100%, or sorry, above or as high as we can get it. To do this, we've also got the PEEP valve attached. It's set at 0 currently, and that's just to prevent the entrainment of room air if the patient does breathe in. The signs that we're looking for signs of paralysis would be a loss of jaw tone and apnea. Noticing that the patient is becoming apneic and starting to lose jaw tone. I'll just give a couple of extra breaths because the last thing we want to do is to pull the bag valve mask away and have the patient entrain room air.
About 45 seconds from rocuronium.
So Alex, the plan from here, when I pull away, will be that you give me the laryngoscope. We'll
Yes.
go for a size 4 initially, and we'll be looking to go with an ETT size 8 for this patient. I may get you to help with head tilt,
Yep.
and lip retraction potentially as well.
Okay. That's a minute since rocuronium.
Okay, and we've got no jaw tone in the happening. Okay, let's go. Slowly. Something. Moving in here. Suction right. Tilt. Moving right to left. You can see the soft palate, hard palate, uvula. I'm moving to the base of the tongue. I can see the epiglottis. I need to move a little bit more distal. There we go. I'm now visualizing the chords. I have a grade 2 view. I have no need to use the suction. Alex, when you're ready, do you mind passing me the bougie curve end down? Thank you. So as I'm passing, I can see it go through the chords. I can feel the cricoid ring vibrations. Now, Alex, can you railroad that size 8 tube over the bougie for me?
Size 8 tube.
Wonderful. Can you hold the bougie? Thank you.
I have the bougie.
Moving the ETT through the chords. I can see the markings in the glottis, noting 22 at the teeth. Alex, when you're ready, can you remove that bougie carefully? Thank you. And I'll just move the laryngoscope. When you're ready, can you inflate the tube with a manometer to 20 to 30 centimeters of H2O?
Inflated to 30.
No worries. And when you're ready, can you get me the tube type, please? Alex, I'll get you to hold the tube, anchoring at the jaw.
Excellent. I have the tube anchored at the jaw.
Alright. Mitch, how are our vital signs doing?
Yep, so we've just hit 95% for SpO2. Everything else is still within normal limits.
Okay. So what we'll do from here, Mitch, I'll get you to oscillate for me.
Yep.
And we'll confirm whether we have placement. Good rise and fall.
Good air entry so far.
So we have good flow. Noting we have a normal respiratory waveform on our ETCO2. Ventilating at about 12 minutes. Also can note misting of the tube as well. And any gastric inflation damage.
Yep, there's no gastric inflation, good air entry in all fields.
Mitch, can you please check that we have a radial pulse and we'll do a reassessment of our patient.
Got a nice regular radial pulse there. Patient's still normotensive, SpO2 is improving.
Wonderful. I've included a troubleshooting guide, and of note we're going to talk about the bevel being caught on the posterior cartilages and burp. Burp is a type of laryngeal manipulation not to be confused with ELM and Selleck's technique that manipulates the laryngeal axis for a better view for the clinician. Another basic technique is the retraction and then rotation of the ETT anti-clockwise to disengage the bevel from the posterior cartilages to gain access to the glottis. Other considerations would be a gastric tube and decompression of the stomach for this patient. We can also manage the patient's temperature and also pre-notify the hospital. Do we have any other queries, and can we conclude the checklist with the post
Yeah, so you've mentioned everything there. So post-RSI checklist, appropriate sedation and analgesia.
Yep. So if we were to find signs of inadequate sedation, such as lacrimation, increasing tone, increasing heart rate, increasing blood pressure or ATCO2, we could sedate the patient with aliquots. Midazolam and fentanyl.
Yep.
Alternatively, we could use a midazolam and fentanyl infusion if transport greater than 30 minutes. This would increase the chance of staying within the therapeutic window and decrease the chance of under sedation. Return of jaw tone and inadequate paralysis would indicate the use of rocuronium.
You reassess the vital signs. We checked the ECT, cuff pressure. You've considered the OGT. You've also mentioned temperature and pre-hospital notification, so that concludes the RSI checklist.
It's important to talk about our ongoing targets post-intubation. So for our ventilation, we can adjust our ventilation rates, our IE ratio and fraction of inspired oxygen to maintain a SpO2 greater than 94% and probably below 98, and EtCO2 between 35 to 45 millimeters of mercury. We also want to target a blood pressure of 120 to 160 for our hemodynamics, controlling our noradrenaline infusion and fluids. We also have temperature control and glucose control.